Hello, everyone. Welcome to February's webinar. Icheche Kujile joining from Port Harcourt, Nigeria. This is the GloDem Training Committee webinar. And our talk today will be on nutritional diseases. Today we have two speakers, Dr. Pablo Fernandez-Gonzalez and Belén de Nicolás from Spain.
Hello.
In today's webinar is Dr. Cindy Sisha Muliro from Tanzania and Emma from GloDem. Next slide, please. Okay, the GloDem Training Committee is the International Alliance for Global Health Dermatology, which aims to promote knowledge equity by improving access to education for dermatology trainees across the world. We aim to provide free educational events and opportunities to build networks and collaborate. Next slide, please. For meeting etiquette, your audio will be muted and your camera will be turned off for the duration of this webinar. If you have any questions or comments, please share through the chat box, and our meeting host will share this with the speakers at the end of the webinar. We'll also be sharing some information about the GloDem Training Committee in the chat function. Next slide, please. Our speakers today are Dr. Pablo Fernandez-Gonzalez. He's a dermatologist in the Ramon Y. Cajal Hospital. He holds a master's degree in tropical medicine in the Autonomous University of Madrid. Also joining Dr. Pablo is Belén de Nicolás. She's a dermatology trainee at the dermatology department, Ramon Y. Cajal Hospital, also in Madrid.
Okay. First of all, I'm going to explain some case reports that we have already seen in our clinical practice. And then Pablo will talk more about the discussion and will explain more about those nutritional diseases. Okay, so I'm gonna start. The first case we are presenting is a 9-year-old girl from Ethiopia that came to the hospital because she had a butterfly-like lesions on the central facial area. She had very limited access to healthcare, so she couldn't come to the hospital previously, but she had these lesions for some months ago. On the physical examination, we saw that the patient was malnourished, that she had a generalized hyperpigmentation. Here we can see those butterfly-like lesions that we have already said, and we see that they are well-demarcated erythematous or hyperpigmented scaly plaques located symmetrically on the malar area. Most of you and us as well, when we listen to this butterfly rash, we usually think about an acute cutaneous lupus erythematosus or systemic lupus erythematosus. However, it's not the only etiology. We can also find this butterfly rash in other diseases such as pellagra. And in this case, further questioning the patient and her family, they told us that their diet was mainly mice-based, which is very low in niacin and tryptophan. So then we diagnosed the patient with pellagra. We started a treatment with a niacin-rich diet, and we also employed some supplements of oral niacin. With this treatment, the patient improved quickly, had a very rapid improvement within a few weeks. And it's important in these patients to maintain a close follow-up because they will probably, they may develop other nutritional dermatosis in the future if they don't follow up this equilibrated diet. What is the differential diagnosis that we should think about in this case? Of course, we should think about a systemic lupus erythematosus because of this butterfly-like rash. However, we can also think of some other diseases that may present with erythematous scaly plaques on the face, such as seborrheic dermatitis, rosacea, or eczema. How can we differentiate these entities from pellagra? Because in pellagra, the patient may also report that they have diarrhea or dementia, other systemic symptoms, and also because of the history of the patient and the diet based in maize or in sorghum, or without enough intake of other foods such as fruit, vegetables, or proteins. We should also think of other photosensitivity disorders, such as some medications or some other medical conditions. What is pellagra? Pellagra, as we have already said, is a disease in which is caused by the deficiency of niacin or tryptophan in diet, and it's usually referred to with a clinical triad of the 3 Ds, which stand for dermatitis, diarrhea, and dementia. If left untreated, we can the patients can evolve to the 4th D, which is death. This in the D of dermatitis is a photosensitive dermatitis. What does it mean? That it affects mainly sun-exposed areas. In the acute phase, patients present lesions mimicking a sunburn with erythema, edema after sun exposure. And these repeated eruptions can evolve to a chronic phase with hyperpigmented plaques with hyperkeratosis and a shellac-like or glassy appearance. As we have already said, lesions usually appear in sun-exposed areas. When affecting the face, we can see this butterfly rash. When affecting the neck and the upper chest, we can see this castle necklace, which is very typical and characteristic of pellagra. And when affecting the dorsal surfaces of hands and feet, we can see the appearance as if the patient was wearing gloves and socks. In conclusion, pellagra is a rare but potentially life-threatening disease. It has a wide range of dermatological, neurological, and gastrointestinal symptoms. It's very important to make an early diagnosis and an early management to avoid the evolution to the 4th D. And it's important to know that pellagra is more prevalent in resource-limited settings. And in these areas, it's important to make a good health education and to promote dietary diversification programs to prevent the appearance of pellagra. In the second case, we are presenting a 56-year-old woman, also from Ethiopia, who presented to the hospital with diarrhea for the past few weeks. And she also reported that she had seen some changes in her skin. What do we see in the physical examination? We see the patient is malnourished, she had a red inflamed tongue, and in the skin, we saw that she presented hyperpigmented, scaly plaques. Where were located these plaques? Also in sun-exposed areas, we saw that she had these well-demarcated hyperpigmented plaques in the neck and upper chest area, as well as in the sun-exposed areas of hands and also in legs. She also reported that her diet was consisting only of maize and sorghum, which are both very low in niacin, and she had a very limited access to meat, dairy, and fresh fruit and vegetables. Therefore, the treatment we started was the same as in the previous case. We started with niacin supplementation, and we encouraged the patient to make dietary changes to ensure an adequate intake of niacin with the consumption of protein, fruits, vegetables. With all these patient symptoms and clinical findings, obviously we made also the diagnosis of pellagra. What is the differential diagnosis that we should think about in this patient? Of course, we should also think of systemic lupus erythematosus, as we already said in the previous patient, but here it's even more important to think of other types of lupus, of cutaneous lupus, such as subacute or chronic cutaneous lupus, because they may present with these scaly erythematous plaques in sun-exposed areas as well. We should also think of other photosensitive dermatoses like porphyria or polymorphic light eruption, because they also have a similar distribution of the skin lesions. Again, we have the clinical triad of the 3Ds, dermatitis, diarrhea, and dementia, but it's really important to take into account and to know that we don't need the 3Ds to make the diagnosis. This is just a classical clinical triad, but not all patients will present with the 3Ds. And we don't have to, we shouldn't wait until the patient presents the 3D to diagnose a pellagra. Even with only the presence of dermatitis, we should suspect a pellagra and initiate the treatment. For example, in this case, the patient didn't have dementia. She just had dermatitis and diarrhea, and we should also diagnose the pellagra. In conclusion, it's important to consider nutritional deficiencies in the differential diagnosis of patients that present with diarrhea and skin manifestations. In the next case report, we are presenting the case of a 3-month-old baby girl who was abandoned by her mother in the street, and she was found by a passerby and brought to the neonatal ward in a rural hospital also in Ethiopia. Upon admission, she was severely underweight and she showed signs of severe dehydration. She also presented a bloating abdomen and she had respiratory distress. These are all signs of a severe malnutrition. In the physical examination, we saw in the mouth that she presented white patches over the buccal mucosa, lips, and tongue. And the laboratory tests confirmed our suspected diagnosis, and she had a candida albicans both in the mouth and in her stool. On the skin, she showed a very scaly, dry skin with rough, discolored patches on the trunk, face, arms, legs, all over her body. All these signs that we have seen in the skin are what we usually know as nutritional dermatosis. We usually call this nutritional dermatosis as the skin lesions that appear in patients with malnutrition. What's the cause of the nutritional dermatosis? It's just the deficiency of essential vitamins and minerals, because all of these elements are important and necessary for healthy skin development. The hair, if we don't have these vitamins and minerals, the hair becomes dry and becomes straight. We can sometimes see the flag sign, in which we see alternating bands of pale and dark color. Usually we see it in long hairs because we need a longer hair to see these alternating bands. Over time, the skin darkens and gets a shiny appearance. The skin becomes very fragile and it starts to peel away, and it reveals an underlying hypopigmentation. And this is the sign that we know as flaking hair paint. We can see some cases which are even more severe than the patient that we have presented in our case. For example, in this case, nutritional dermatosis has progressed to a striking exfoliative dermatitis. It's important to know that there are no blisters. It's just the skin who is detaching. There is an epidermal detachment in large plaques, and it leaves that picture in flaking hair paint. It's important not to be confused with other disorders, like autoimmune blistering disorders or staphylococcal scalded skin syndrome. The treatment that we established in this patient was with intravenous fluids to rehydrate the patient and to provide her the essential nutrients that she needed. And we maintained a very close monitoring and supportive care. As the baby's nutritional status improved, skin lesions began to heal and her weight hopefully began to increase. In the next case report, we are presenting a 15-year-old boy that was brought to the hospital in Mali because he reported night blindness for several weeks. On the physical examination, we saw that he presented conjunctival and corneal cirrhosis. And when talking about the skin, he presented dry, rough skin. And we saw also some hyperkeratotic follicular papules who were located on the buttocks and on extensor surfaces of upper and lower limbs, which is called phrygnoderma. Here we see these hyperkeratotic papules located in the hair follicles. And you can see also here these follicular papules with hyperkeratosis in the dorsal and extensor surfaces of upper and lower limbs. We made the patient a blood test which showed low levels of vitamin A. So we diagnosed the patient with vitamin A deficiency. The treatment consisted in vitamin A supplements, and we also encouraged the patient and his mother to increase his intake of vitamin A-rich foods, such as eggs, liver, leafy green vegetables, or carrots. Once he started with the supplements of vitamin A and he increased the consumption of these foods, the skin lesions healed and night vision was restored. The fifth case is also a baby girl, a 3-month-old girl that we saw in our hospital here in Spain. She was diagnosed with maple syrup urine disease, which is a rare metabolic disease caused by the deficiency of an enzyme that is important for degrading branched chain amino acids, such as leucine, isoleucine, and valine. The treatment of this disease is restricting these branched chain amino acids in diet. However, as they are important for daily living, because they are essential amino acids, we have to give them to the patient to be alive, but we have to restrict it, and we cannot give them a very high doses, because if they receive high doses of these amino acids, as they cannot degrade them, they may present severe neurological symptoms. And what happened with this patient? The parents made a mistake, an error in the dosage of her food supplements, and they gave her too high levels of isoleucine and valine. Therefore, as she couldn't degrade them, she presented to the emergency department with severe neurological symptoms, with seizures and confusion. Therefore, she had to be initiated on extrarenal clearance to reduce these amino acids levels. And as a result of all this process, after all the process, she presented very low levels of isoleucine. What happened next? As she presented very low levels of isoleucine, she presented with these skin lesions. She presented scaly erythematous plaques in the neck and extremities, and also presented erosions in perioral, perianal, and axillary and nuchal folds. In the lab tests, we saw that she presented very low levels of isoleucine with normal levels of zinc. As once she was supplemented with isoleucines and her levels were corrected, the skin lesions began to heal, and they improved very quickly. What's the diagnosis of this patient? The diagnosis is acrodermatitis dysmetabolica. And what is this? Acrodermatitis dysmetabolica is clinically similar to acrodermatitis enteropathica, which is caused by zinc deficiency. Both present with the clinical triad of periorificial and acral dermatitis, diarrhea, and alopecia. However, acrodermatitis dysmetabolica is not caused by the deficiency of zinc, but is caused by the deficiency of essential amino acids and fatty acids. And this can be seen in numerous metabolic disorders, such as maple syrup urine disease, but also in other metabolic disorders, as you can see in this slide. What should we think about in the differential diagnosis of this patient? Of course, we should think of acrodermatitis enteropathica because of zinc deficiency, but we should also differentiate AD with other dermatoses that may cause erosions or even large erosions in babies or in infants. Some of these diseases are, for example, staphylococcal scalded skin syndrome, Stevens-Johnson syndrome, epidermolysis bullosa, or even pemphigus vulgaris. But not only erosions, because as we have already said in the case, the patient also presented with erythematous scaly plaques. So we should also then make the difference with other diseases that present with these erythematous scaly plaques, such as lichen planus or psoriasis. The last case we are presenting now is a 34-year-old male patient that was admitted in our hospital in Spain in internal medicine because he was in severe malnutrition. He reported that he had a very low income and he couldn't afford fresh fruits and vegetables because they were too expensive. And therefore his diet consisted almost exclusively of milk and bread. He reported that he had fatigue, weight loss, muscle weakness. He also had gingival bleeding, impaired wound healing. what did we see in the physical examination? We saw that he presented follicular hyperkeratosis and perifollicular hemorrhages with petechiae and coiled hairs or corkscrew hairs. Some of these petechiae confluted into large ecchymosis on both sides with an appearance like podogans. He also presented dry and rough skin, and on lower legs, we saw that he had several ulcerations with areas of sloughing and necrosis. Here you can see the pictures of the large ecchymosis that presented on both sides, as well as here the perifollicular hemorrhages and these coiled hairs or corkscrew hairs. We performed a skin biopsy in which we showed that the patient had hyperkeratosis, acanthosis, and perivascular lymphocytic infiltrates without an evidence of vasculitis or thrombosis. In the lab tests, he had low levels of vitamin C, as well as low levels of iron and albumin. As a result, we diagnosed the patient with scurvy, which is the deficiency of vitamin C. We started the treatment with high-dose vitamin C supplementation, as well as we encouraged the patient to have a well-balanced diet, including fruits and vegetables, diary. After we started this treatment, the cutaneous manifestations improved within days, and the ecchymosis and hyperpigmentation also resolved. However, the leg ulcerations required local bound care, and they had a slower healing within several weeks. In the differential diagnosis of macular ecchymosis, apart from the deficiency of vitamin C, we should also think of in the deficiency of other vitamins, such as vitamin K. We should also think that the patient may have any kind of coagulopathy. And also we must investigate for the use of anticoagulants or the use of topical or systemic corticosteroids. And with this case, these are all the cases that we wanted to tell you, to present you. I hope you have find them interesting. And now Pablo is going to explain more about these diseases, and he's going to tell you the clinical clues to suspect one or another. And I'm sure you will enjoy a lot of what he's going to tell you, because I'm sure he loves the topic he's talking about, and he will explain it absolutely good. Okay, so I leave you with Pablo.
Hello, everyone, and thank you, Belén, for your very nice presentation and for your great presentation, not just the cases, but my presentation. Yes, I am Pablo Fernandez. I'm part of the staff in the dermatology department in Hospital Ramón y Cajal here in Madrid. And now we're going to make a discuss about different manifestations, cutaneous manifestations of some nutritional diseases that we can see not just in other places or in other countries, for example, where we see lots of nutritional deficiencies, but also that we can see in our area, in our hospitals or in our clinics. Well, the objectives of this discussion, the main objective of the talk is to educate on how essential nutrients in the diet play an important role in skin health, and how a lack of nutrients can lead to a variety of dermatosis. Also, we're going to identify the signs and symptoms of dermatosis associated with nutritional deficiency. And finally, our aim as dermatologists is to provide the audience some practical advice on how to prevent and treat dermatosis associated with nutritional deficiencies in order to be practical in our daily practice. To facilitate the navigation through the presentation and through the slides, I have created these icons where to highlight some parts of the presentation. For example, the blue highlights will mean the cutaneous findings of the nutritional deficit, which are the main and the most important cutaneous findings that we can see in those nutritional deficiency. The pink highlight is about the systemic manifestation, associated with the deficiency. On green, we will see the diagnostic clues. I mean, those signs or those symptoms that are important or are the key to make a correct diagnosis. And also in yellow, we will see some precautions or some interesting things that we have to know about one or another disease. So let's start with vitamin A deficiency. Vitamin A is a fat-soluble vitamin found as retinol esters in milk, fish oil, liver, and eggs, as carotenoids in plants. Vitamin A deficiency is common in children in the developing world, but it is rare in developed countries, where it is most often associated with diseases of fat malabsorption, such as bowel bypass, inflammatory bowel disease, pancreatic insufficiency, or celiac disease. Vitamin A is required for the normal keratinization of many mucosal surfaces, and when it is deficient, the resultant abnormal keratinization leads to increased mortality risk from inflammatory disease, along with other manifestations in the skin and other surfaces. But we have to take into account that the patients with vitamin A deficiency has more risk of developing pneumonia due to measles. Well, although Fernandez-Gonzalez had classically been ascribed to vitamin A deficiency and is the most most important cutaneous finding, it can be also found in other vitamin deficiencies, such as other vitamins B, vitamin C, or vitamin E. This skin eruption, also termed as follicular hyperkeratosis, resembles keratosis pilaris and is very similar to this manifestation that we see in atopic dermatitis patients, for example. It consists of keratotic papules of various sizes distributed symmetrically over the extremities and shoulders, and surrounding and arising from the pilosebaceous follicles. The individual lesions are usually asymptomatic, pigmented papules that contains a central intrafollicular keratotic plaque that projects from the follicle as a horny spine. Lesions are two sides. The most common are about 1-2 millimeters papules closely resembling to those seen in keratosis pilaris. But we can also find larger lesions about 2-6 millimeters that may resemble perforating dermatosis. So this is important to know to make a correct also the differential diagnosis between these two conditions. The hands or feet are not usually involved, and the lesion occur only occasionally on the midline of the trunk or in the axillary and anogenital areas. The most common part that we find these lesions are around the abdomen or around the thighs. We can also find in vitamin A deficiency generalized dryness, fine scaling, and hyperpigmentations. Also important, vitamin A deficiency may mimic vitamin C deficiency, scurvy, that we will talk about later, because both conditions affect the follicular unit. Here we can observe the characteristic plaque around the follicles that is very characteristic of this phrynoderma, these cutaneous lesions in vitamin A deficiency. See that they may resemble keratosis pilaris. So this is important to know and to make the differential diagnosis when we see a person who may be malnourished and have these lesions. Here we see the lesions of the case report that Belén has presented. See that they may appear in the buttocks as well. And here with a picture in more detail, how these lesions may resemble keratosis pilaris. So think with these lesions in a correct context, think about vitamin A deficiency. And what about the diagnostic clues? Well, B dot spots, which are these spots that arise in the conjunctiva of patient affected by vitamin A deficiency. Also, symptoms, important symptoms associated to this deficiency, eye findings, night blindness, xerophthalmia, xerosis corneae, and keratomalacia. Okay. Also important, the treatment is the supplementation with vitamin A, about 100,000 units per day during 2-3 days. But the important that we have to know is that we find a rapid and very quick improvement, especially of the eye findings or the ocular findings and ocular symptoms. So this is very useful because if we do not have the possibility of make the levels of the vitamin A, because we are in a rural hospital in the middle of the mountains and we don't have those laboratory tests, we can treat the patients and see the outcome. Well, what about water-soluble vitamins? Vitamin B1, B2, B6 have very similar cutaneous manifestations. You have to remember that all of them may cause oral and tongue manifestations, and tongue depopulation and alteration in those surfaces. Other specific changes that we can find regarding different vitamins, for example, it's important to know that the deficit of vitamin B2, riboflavin, may produce a seborrheic dermatitis-like eruption in this patient. So I know that seborrheic dermatitis is very common in our daily practice, and we do not usually suspect vitamin B2 deficit in our patient. But I insist, in a correct context, in a compatible context, we should think about these deficits. About B1, thiamine, again, edema, red burning tongue, but think about neuropathy, a patient with neurological symptoms, peripheral neurological symptoms, or very with this depopulation of the tongue, maybe a vitamin B1 deficiency. Pyridoxine, it's important because usually it is associated to pellagra. Pellagra, we are going to discuss in more detail in the next slides, but many of our patients with pellagra have also tuberculosis. They are under tuberculosis medication, and they may have as well pyridoxine deficit. And the deficit of vitamin B6, the deficit of pyridoxine may worsen the symptoms of pellagra. So remember in the cases of pellagra, in the cases of deficit of niacin, also supplement or search a deficit of vitamin B6, especially in those patients that are treated for tuberculosis. This is a depopulation of the tongue. So in an adequate context of malnutrition, think about vitamin B, B1, B2, B6 deficit, okay? Also B12. But about vitamin B12 deficiency, vitamin B12 is absorbed through the distal ileum after binding to gastric intrinsic factor in an acid pH. Deficiency of vitamin B12 is caused mainly by gastrointestinal abnormalities, ileal diseases, and malabsorption syndromes. Glossitis is common to find in a patient with vitamin B12 deficit, but a clue to the diagnosis is hyperpigmentations and canitis, which are the main dermatologic manifestation of vitamin B12 deficiency. What about this hyperpigmentation that we can find in this deficit? The hyperpigmentation is generalized, but more often it is accentuated in exposed areas, such as the face and hands, and in the palmar creases and flexors, resemble Addison disease. The nails also may be pigmented, and another interesting feature that we can see in vitamin B12 deficiency is premature gray hair, which occurs paradoxically because we can see hyperpigmentation in some parts of the body, but the hair may have this premature gray stain. Think also about folic acid deficiency if you see this manifestation, because this deficiency may resemble, the folic acid deficiency may resemble vitamin B12 deficiency. So also in a context of a person with malabsorption syndromes, with malnutrition, or with some diets, think not just with hyperpigmentation and this manifestation we have talked about, think also about folic acid deficiency along with vitamin B12 deficiency. Here, I want to show you some cases from case reports in PubMed, in the literature, to see this hyperpigmentation that we can see in this vitamin B12 deficit that may precede neurological symptoms. So this is important. It's important to diagnose, to do a prompt diagnosis of this deficit before other more severe symptoms. Here, there's another case, seeing this hyperpigmentation, this diffuse hyperpigmentation in the lower limbs associated with megaloblastic anemia. Well, vitamin C. Vitamin C is essential for collagen synthesis, which is a protein that provides structure to tissues such as skin, bones, and cartilage. Without an adequate vitamin C, the body cannot make collagen, which can lead to weakened connective tissues and impaired wound healing. Scurvy, or vitamin C deficiency, is often diagnosed by dermatologists because cutaneous manifestations are early and prominent. Some of the risk factors to develop this deficiency are elderly male alcoholics and patients with behavioral health and autism spectrum. Also, other risk factors may be iron overload due to multiple transfusion, neurological disorders, smoking, or a story of chemotherapy and dialysis patients. About the cutaneous findings, the most important, as Belén has told us in her presentation, are the perifollicular petechia. Perifollicular petechia are the characteristic cutaneous finding, and in addition, ecchymosis of various sizes, especially on the lower extremities, are very common. Also, the hair shafts may appear curly in follicles and surrounded by keratotic plaques in a distinctive findings, which is called corkscrew hairs. Remember those hairs, those corkscrews hair, those curly hairs with this hemorrhagic follicle, because this is very characteristic of scurvy of vitamin C deficiency. Here we see in more detail these follicles, these hair shafts. Purpura also is a common manifestation of multiple diseases, but in scurvy we see in this perifollicular pattern that is very characteristic and we have to know. Remember also that a severe malnutrition, with a severe vitamin C deficit, we can see multiple ecchymosis and large ecchymosis. What about diagnostic clues? Gingival hyperplasia and gum bleeding. Hemorrhagic gingivitis occurs adjacent to teeth and presents as swelling and bleeding of the gums. This is very important because it will be worse in patients with poor oral hygiene. And also we have to look for anemia because these patients, especially those with a chronic deficit, with long-time vitamin C deficit, may have blood loss. So they will develop eventually anemia. Also, other types of blood loss are frequent in patients with severe scurvy, such as epistaxis or other bleeding in the organs. Here we can see another example of gum hyperplasia, and this finding may be, I insist, a diagnostic clue. The diagnosis of scurvy is usually made on clinical grounds and is confirmed by a positive response to vitamin C supplementation, very similar as what we said in vitamin A deficit. And also, with a supplementation of vitamin C, the symptoms, and especially those which are more severe, improves quickly. So this is important, and this is also a clue for us to make the correct diagnosis. Okay, what about vitamin B3 deficiency? Niacin or nicotinamide, depending on how do you want to call it. Well, the main disease associated to niacin deficiency is pellagra. Pellagra usually results from a chronic deficiency of this vitamin or its precursor amino acid, which is tryptophan. It is associated classically with a diet almost entirely composed of corn, and this is very important, and this may be a clue for the diagnosis of this disease. Most of the patients with primary pellagra are people who doesn't take any food, malnourished, total malnourished people, or patients with a exclusively corn diet, patients that do not take anything about but corn or corn derivatives food. Malnutrition or other vitamin deficiency, especially pyridoxine, which interfere with the conversion of tryptophan to niacin, often coexist. So this is very important, especially in patients treated with isoniazid for tuberculosis. In developed countries, most cases of pellagra occur in alcoholics or other types or other diseases of malabsorption, such as inflammatory bowel disease or other types of restrictive diets, and also Hartnup disease. Well, what about the cutaneous findings? The most important and systemic findings that we find along with the cutaneous findings are the 3Ds disease: diarrhea, dementia, and dermatitis. And about the eruption, the RAS, we have to note that it's a photosensitive eruption. We will see the skin lesions in the areas exposed to the sun: the face, the hands, the area of the upper chest, okay, which is called the casal necklace. And initially, there is erythema and swelling after sun exposure, accompanied by itching and burning or pain. But in chronic lesions, we can see more thicker skin, and lesions more similar or that may resemble lichen chronicus, more lichen. Well, the cases presented by Belén and the cases we are going to see in the next slides are from Ethiopia, in a rural hospital, where we saw many cases of pellagra, because in this is a very poor area of the country where many patients and a lot of people have a diet exclusively based on corn. Remember that the most characteristic cutaneous findings are those patches and this rust associated with photo exposure. It occurs usually symmetrically on the face, neck, and upper chest, and the rust usually affected these areas, but not always. In some patients, we can see just the lesions around the neck. In other patients, we can see in the arms or just in the face. It depends also in the time of evolution in the chronicity of the lesions. After several phototoxic events, thickening, scaling, and hyperpigmentation of the affected skin may occur. The skin in these cases has a copper hue or stain, and as I told you before, in chronic cases, the skin ultimately becomes dry, smooth, paper-thin, and glassy, with a parchment-like consistency. But scarring or scar changes are not usually, does not often occurs. Here is a case of an old man who had a severe and long vitamin B3 deficit because he ate just corn. His diet was based almost exclusively in corn. Also, in severe cases, the eruption may be vesicular or bullous, also known as wet pellagra. But in my experience, I haven't, I've never seen a wet pellagra. The majority of the cases are as we have presented in these cases. Remember also this butterfly lupus-like rust that may resemble a lupus erythematosus. And here we have other cases from the books. Remember then that pellagra also occur in people with malabsorption syndromes, alcoholics, or people with patients with restrictive diets, with very severe restrictive diets. Here's another case of gumbo. This case was totally like the ones we study or we see in the books. Here you see the causal signs, the lesions in the upper part of the chest that are very characteristic of pellagra, of vitamin B3 deficit. Let's see here the examples. This is another case of gumbo. This is a case that has presented Belén. It was a case of protein malnutrition, but in this case, the child was again just having a diet based on corn. So we had malnutrition, protein malnutrition, and also these pellagra changes. And another case from gumbo, this time from my friend Dr. Eduardo Malmierca, and look at the copper-like tone, dryness, and fine peeling, so characteristic of this disease. Also important, as we can see in other vitamin B deficiency, also in pellagra we can see oral manifestation, oral changes. Well, and what about the treatment? Well, first of all, it is necessary to know the disease and suspect it in time. Of course, supplementation is a quick option for healing and also allows us to make the diagnosis when we have doubts, the same as we saw in vitamin C deficiency or vitamin A. Since the patient will improve quickly. Above all, the diarrhea and neurological manifestations are the first manifestation of improving when we make the correct diagnosis and we treat the patients. On the other hand, changing eating habits is mandatory, but not always possible, of course. Here, it can be very useful to carry out the nixtamalization process, which is a process well known in South America for the treatment of corn and which allows to release the niacin contained in the grain of the maize. On the other hand, the vitamin enrichment policies of the flowers that are marketed is also very useful. And something very interesting that I want to share with you is coffee. Roast coffee has high amounts of niacin. So it's a cheap, useful, available treatment in some areas where you cannot find the pills of niacin, which is the mainstay of treatment. But if you find yourself in some lost place, you can use roast coffee to treat pellagra. Well, let's talk a little about acrodermatitis enteropathica due to zinc deficiency. Zinc deficiency may be an inherited abnormality or it may be acquired, okay? Acrodermatitis, but also acquired cases are termed as acrodermatitis enteropathic-like syndrome, which can be seen in many metabolic disorders as the one Belén presented before, who was a girl suffering from maple syrup urine syndrome. So in one side, we have those cases produced by a zinc deficiency, and on the other side, we have a very similar cutaneous finding, a very similar cutaneous syndrome like the one she talked about, but which are produced by many metabolic syndromes, okay? In the case of zinc deficiency, well, premature infants are at particular risk because of inadequate body zinc stores, suboptimal absorption, and high zinc requirements. Normally, human breast milk has adequate zinc, and winning classically precipitates clinical zinc deficiency in premature infants and in infants with acrodermatitis enteropathica. So what we see in these patients, we see diarrhea, alopecia, and dermatitis, which are symptoms that may be a clue to the diagnosis. But also, don't just think that there are some patients that may have a zinc deficiency, not just only because they have problems in the absorption, they have problems in their metabolism, but also because some mothers have low maternal breast milk zinc levels. So in some cases, we have to make the supplementation or change the milk formula to feed the newborn. Also, think about a possible acrodermatitis enteropathica or zinc deficiency in those patients with a chronic diaper rash. This is very important, and this is a manifestation that sometimes missed. Well, what about the cutaneous findings? The dermatitis in all forms of zinc deficiency may be pustular and bullous, but the lesions are often flaccid, leading to the clinical appearance of crusting. Okay, it is important that they usually have an acral and periorificial distribution, affecting not just the hands, the feet, but also the mouth, the oral cavity, the perioral skin, and also perianal or perigenital skin may be also affected. Angular cheilitis and stomatitis and oral changes are also seen in these syndromes. Think not just think about this syndrome in the acute phase, when we see those pustular and bullous lesions, but also in a newborn with chronic lesions, psoriasiform lesions. We have also think about this syndrome. Again, also if it is associated with generalized alopecia. Okay, the chronic lesions may be more psoriasiform, and it depends in the time of evolution. What about the acrodermatitis dysmetabolica, which is this cutaneous syndrome very similar to acrodermatitis enteropathica due to zinc deficiency, but which is produced by other metabolic diseases? Well, one of these metabolic disorder is maple syrup urine disease, the one that Belén has presented us. This is a genetic deficiency of branch chain alpha ketoacid, the hydrogenase, which, to summarize, makes the high levels of branch amino acid that produces neurological symptoms. So these patients is very important. The patients with maple syrup urine disease, this patient is very important that they have a diet with low intake of these amino acid foods, containing foods, because they may or develop eventually neurological symptoms. But in some cases, when they have very restrictive diets for this toxicity for these amino acids, they may present a very low intake of leucine, and they will develop these cutaneous lesions because the amino acids are needed for the correct development of the skin, and if the diets are too restrictive, they can develop a syndrome very similar to acrodermatitis enteropathica. So very important in this patient to have a correct balance between the intakes of the foods containing these amino acids to prevent neurological symptoms, but also to have an adequate level of the amino acid to develop the skin of the newborn. Well, perioral lesions, along with the upper rash, the diarrhea and alopecia are key of diagnosis. So think in this syndrome, when you see chronic diaper rash, periorificial symptoms, periorificial dermatitis in a newborn, and also alopecia. Okay. This is another example of perioral dermatosis due to this disease. Look that in some cases it may resemble seborrheic dermatitis. So this is another interesting feature, another interesting manifestation to think about. And it is very common that the area around the neck is affected. In this case, as you see, the child developed blisters that now are broken, and it's very similar as the case we saw in our hospital and has presented. So think also about this syndrome with in your differential diagnosis of bullous diseases. Some of the cases may even resemble burns in this perianal area, and despite of the case we saw in our hospital did not have this kind of lesions, it is not rare that some cases present with pustules, that not just blisters but also with neutrophil amounts containing blisters. So to summarize, the diagnosis of zinc deficiency should be suspected in at-risk individuals with acral or periorificial dermatitis. In particular, as I told you before, chronic diaper rash with diarrhea in an infant should lead to evaluation for zinc deficiency. The diagnosis can be confirmed by low serum zinc levels. If we have the opportunity to make those tests in our hospital, but also we can make the supplementation and see the outcomes. Well, regarding protein energy malnutrition, this is a very interesting, very important, and very frequent topic. Protein energy malnutrition is a spectrum of related diseases, including marasmus, kwashiorkor, and marasmic kwashiorkor. These conditions are more common in parts of the developing world, in some parts of rural areas or very poor areas where the children have very low food and very low food intakes. Marasmus represents prolonged deficiency of protein and calories and is diagnosed in children who are below 60% of their ideal body weight. Kwashiorkor, in contrast, occurs with protein deficiency, but a relatively adequate calorie intake. For example, a child who is fed just with corn flour or corn products. These conditions, despite of they are rare in developed countries, we can also see in our hospital, in our daily practice, in some patients with restrictive diets, alcoholics, homeless, or other types of syndromes. And about the systemic symptoms that we can find in these malnourished patients, it's important that they have a very increased risk of pneumonia and other infections. Well, in cases of marasmus, the skin usually is dry, wrinkled, and loose because of marked loss of subcutaneous fat. The loss of the buccal fat pad is very characteristic. In contrast to kwashiorkor, there is no edema or flaky dermatosis. They have usually dry, thin, pale lacs and fine descamation and hyperpigmentation. Also think that this patient may have hemorrhages, purple, and may resemble to scurvy. And also think that a child or a person with a malnutrition, with a severe malnutrition, not just energy or protein malnutrition, will almost always will have another vitamin deficiency. So think about multiple deficits when you face a patient with malnutrition. Here we see an example of a patient with a very low calorie intake, chronic low intake with the arm test. Well, about kwashiorkor produces hair and skin changes, and very specific hair and skin changes, but also edema, impaired growth, and a characteristic pot belly or ascites. The skin lesions that we see in kwashiorkor are hypopigmented on dark skin and erythematous or purple on lighter skin. In my experience, I have seen most in dark skin. Lesions first appear in areas of friction or pressure, the flexors, groin, buttocks, and elbows. Hyperpigmented patches occur with slightly raised edges. As they progress, lesions resemble old, dark, deteriorating enamel paint or flaky paint, the one that we see, for example, in old cars, in old painted houses, those flaky paint, or peeling with descamation. The hair and skin changes are usually strictly. The hair also can be hypopigmented and the color may vary from a reddish yellow to gray or even white. The hair also is dry. Curly hair becomes soft and straight and with a marked scale. Also remember the flag sign in cases where the patients have long hair. Here there are some examples of what is when we refer flaky paint or grassy paving that has also been described like this grassy paving or this flaky paint. We're going to see some examples. Here we can see pigmentary changes in these childs. Let's see these areas of hyper and hypopigmentation in the front skin. This child was also in the neonatal, in the child ward in the hospital of Gambo. Also, it's very characteristic these hypopigmented macules. Okay, in the see this hypopigmentation changes in the lower jaw. This child had a mixed malnutrition, kwashiorkor and marasmus. But this is very characteristic. This is not fungal infection. Well, you have to do the differential diagnosis, but this is different. This is because the low protein intake. See here, this is a case from the book, hyperpigmentation in the front skin of a child. Let's observe that chronic lesions may resemble chronic eczema or even psoriasiform dermatosis. And also, this following case may appear as a bullous dermatosis, but I want to insist that we are facing an exfoliative dermatosis. Here, the problem is that the skin detached. This is not epidermolysis. This is a detachment. So there are different diseases. Okay, if we see blisters, we have to think about other diseases, impetigo, pemphigo. Okay, but see that the skin is peeling. This is associated. This is very in a correct context. This is an important association with malnutrition with kwashiorkor. Okay. So I think that this is of utmost importance to be aware of this manifestation, given that malnutrition, especially in children, can be observed in many parts of the world, and cutaneous manifestation in these children is very frequent. Here we can see the child of the case that Belén presented. See this mild exfoliative dermatitis with pigmentary changes. Look also the intense ascites that this patient present because of the kwashiorkor, because the low protein intake, the malnutrition. And this case that shared with me a colleague who was working in Angola. I think this is very useful, this picture, to know the characteristic cutaneous manifestation in kwashiorkor. Let's see that there are large parts of skin detached with hypopigmentation. Okay, this is not, I insist, bullous dermatosis. This is because the malnutrition. Okay, another case in an adult with the same clinical manifestation. Also, it may happen in adults. Remember that in some chronic cases, the lesions, and also in patients with clear phototypes 1, 2, the lesions may resemble eczema, psoriasis, and instead of hyper and hypopigmentation, they appear as erythema. Okay, this is another case. And last but not least, remember that a malnourished patient can have several vitamin deficiencies simultaneously, not just one. We explain one by one the deficiency because it's more useful to understand them. But most of the cases, an alcoholic patient, for example, will have low levels of niacin, of pyridoxine, low protein intake, low vitamin C intake. So always think, open think and think beyond just one deficit, okay? So these are just the summarize of the deficits, but I think we are out of time. So thank you very much to all of you for your attention. Thank you very much for joining us to these sessions. I hope this will be useful for all of you, for dermatologists and not the dermatologists who have to face these cases sometimes in places with low resources where it's difficult to make diagnosis, to test, to make tests, to find a specialist, for example. So I hope this will be useful in your daily practice. Belén and I are very happy to answer any questions you have. Thank you very much again, and thank you to Glodram Training Committee for giving us the opportunity of sharing with you this knowledge. Thank you.
Thank you too.
All right, thank you. Thank you, Dr. Pablo and Belén. Now we take questions from the chat box, and Dr. Cindy would anchor that. Now, Dr. Cindy.
Thank you, Iche. Thank you, Dr. Belén and Dr. Pablo, for that amazing and comprehensive lecture. We have a few questions in the chat box and the Q&A section. I'll start off with the first one. Thank you for a wonderful presentation. Hoping to get a lecture next time on effects of excess vitamin supplementation on the skin, if there are any. And the question is concerning vitiligo patients. What is the role of pyridoxine supplements when treating vitiligo patients?
So treating vitiligo patients, which is the role of?
Pyridoxine supplementation.
Pyridoxine in vitiligo, pyridoxine. Well, I'm not familiarized in the treatment of vitiligo with that vitamin. In my opinion, vitiligo is an autoimmune disease. So the mainstay of the treatment of this disease will be, the corticosteroids, also UVB, but I'm not familiar. I don't know if the supplementation with pyridoxine can improve the symptoms of vitiligo. I'll have to check it. But in my opinion, the mainstay is to decrease the action against the melanocytes with topical corticosteroids, topical tacrolimus, and also phototherapy.
Okay, thank you. We have another question where they're asking, in management of acrodermatitis dysmetabolica, is there a role for topical zinc ointment as well as the use of mupirocin for possible bacterial superinfection?
Well, in acrodermatitis dysmetabolica, it is defined by normal zinc levels, because this is acrodermatitis enteropathical-like syndrome, because the manifestations are very similar to those seen in zinc deficit, but with normal zinc levels. So in this case, I think that topical zinc will not be very useful. In the case of acrodermatitis enteropathica, in which the main cause of the syndrome is the zinc deficit, in this case, well, it may be interesting to perform, to do the healings, to heal and to treat the erosions and the skin manifestation and skin lesions with topical zinc. But the more practical thing to do in these patients is to give them zinc supplementation, because they will improve very quickly. So oral supplementation with zinc, and it will be enough. Also, mupirocin and other topical antibiotics are indicated, are also a very good option to treat the skin lesions, to avoid and to prevent superinfection or bacterial infection of the skin lesions that may be another problem, another important problem in these patients.
Thank you. There's another question where someone is asking if, for example, you are not able to manage the diet, the patient is unable to afford appropriate diet, they tend to focus more on the drugs. Would you also advocate for this?
Well, I will focus the treatment in the diet, because if, as I told you, a malnourished patient, it's very rare to have just one deficit. So if you find a person with a niacin deficit, but also a vitamin C deficit, he or she has to buy 2 supplements, and maybe it's better to use that money to buy food, to buy poultry, to buy meat, to buy liver, for example. Beef liver is very useful in the treatment of all types of deficiency, because it has a high amount of vitamins. But it's difficult, the pharmacological treatment of these deficiencies, because again, in some places we don't have the pills. You can find the pills. For example, when we were to Gambo and we tried to treat the pellagra patients with supplements of niacin, we couldn't, because we had not that supplements. So I think that it is more important to teach the patients how to prevent these deficits.
Okay, thank you. Another question, is there a role, other than the supplementation of vitamins, is there a role for emollients like Vaseline, Aquaphor in the treatment of these disorders?
Well, of course, apart from the treatment of the vitamin deficiency, it's important also to make a local wound care. For example, in acrodermatitis enteropathica or dysmetabolica, if you have erosions, it's important, for example, to use Vaseline with some gauzes to prevent superinfection of the wounds. It's not the treatment itself, but it can help the skin lesions to heal earlier and better. Of course, also Zika or Aquaphor, they also promote regeneration, reparation of the skin. So they of course they can help if they are available where we are. They can be, of course, a good idea to complement the treatment that will be the diet and the oral supplements.
Thank you. For the final question, we have learned different ways of treating pellagra. I personally found it interesting, or I've learned new information about treating with roasted coffee. We use a lot of nicotinamide to treat pellagra. So what's your comment on that, especially when it comes to dosing?
When it comes with dosing of nicotinamide?
Yes.
Yes, if nicotinamide as pills or niacinamide or niacin is available, that is the best way to treat a pellagra, because the patient will improve very quick, and then you can maintain the supplementation for 3-4 months, and then to teach the patient how to prevent the appearance or the flares of pellagra. But the problem again is in some places you don't have niacin or nicotinamide, so you have to find another ways to treat the patients, or to give them instructions, or give them tools to have those intakes that are missed. But yes, I totally agree. If nicotinamide or niacin tablets are available in your area, in your ground, use them.
Okay. Thank you. That marks the end of our question and answer session. So back to you, Iche.
Thank you very much.
Thank you.
Thank you once again, Dr. Pablo and Belén, for an enlightening lecture on nutritional diseases. We look forward to having you sometime again in the future, and we look forward to more collaborations. So,
Thank you to you for inviting us.
Thank you. It was a pleasure.
yeah. So thank you everyone for joining this presentation. We hope to have you again for another Gluten presentation next month. We'll see you all. Thank you very much and goodbye.
Bye-bye. Have a nice day.
Bye.
Bye.
Yeah, goodbye. Goodbye.